So we're going to be kind of continuing on from where we were with this first ray discussion. Last time we spent some time talking about the valgus rotation of the metatarsal that goes along with bunions. And I like to think of bunions as being caused by, these being the cause of inflammatory disease, being rheumatoid arthritis, gout, and the like. That's pretty obvious. Trauma, any damage to the medial collateral structures can result in a bunion formation. Valgus torsion, the first metatarsal, we'll spend a couple minutes on, but we're not gonna spend as much time as we did on it last time. And this really started from this study that Pusinelli presented at the Podiatry Institute meeting in San Diego in 2016, where they did some weight-bearing evaluation of the first metatarsal and hallux abductor valgus with computed tomography, measuring the frontal plane rotation of the metatarsal head relative to the ground. And they had a series of 30 patients with bunions and 30 patients with hallux limitus. And if I can get my pointer to work here, the frontal plane rotation was that rotation of the crista that we looked at just a minute ago. In the bunions, it was averaged 18.9 degrees. In the patients with hallux limitus, averaged 2.9 degrees. And this was about the time that the business of pronation of the first metatarsal was starting to catch on as being one of the main causes. People were talking about derotational lapidus. And their conclusion when they did this study in 2016, that was perhaps the bunion was driving this increased pronation of the first ray. And I wasn't too sure of that. And then in 2017, Oda came out with a paper and they talked about the first metatarsal torsion. And they saw a significant increase in external torsion with hallux abductor valgus. It did not seem to increase with severity of the deformity. And they thought maybe it's not a result of the deformity, but a predisposing factor. And they again had kind of similar numbers. It was like 18 degrees with bunions for that frontal plane rotation and 4 degrees for controls. So now we had one saying maybe it's pronation, one saying it's rotation. Most of the literature to that point had been talking about pronation. So Allison McNamara wanted to do a study, and I got together with her, and we did this little study that we talked about last time. Whoops. I know for you guys, are the picture, your picture's on top of that, I suppose. The peak of this graph, see, how can I get this to, yeah, I can move this over. Let me move it over. Anyway, what we found was that there's a regular, they took 100 patients and just did the study, and we measured a whole bunch of things: navicular first cuneiform, first metatarsal base, first metatarsal head, second metatarsal. And the bottom line was we came out with an average amount of torsion of the first metatarsal as being right around 10 degrees. So the average individual has about 10 degrees of torsion. The people with bunions have a higher degree. People without bunions coming out here closer to 90 degrees. Nobody had varus torsion of the first metatarsal relative to the first metatarsal base in this study. So valgus torsion of the first metatarsal, I think, is a predisposing factor. It's, I don't think there's much question about it. There's been 2 or 3 articles coming out every year since that time to kind of show this.
Yeah, he did really good.
So let's talk a little bit about abnormal foot function. What kind of abnormal foot function causes bunions? Tom, have you got a suggestion on what would cause it?
I'm sorry, I was muted. Can you repeat the question?
I know you're sleep deprived.
Not quite.
You will be next week.
Yeah.
So abnormal foot function. What kind of abnormal foot function causes bunions?
Overpronation.
Overpronation.
dorsiflexion of the first ray?
Right, so first ray instability.
Hmm.
So I look at it with this kind of a diagram here, that the subtalar joint pronation is certainly a cause. But subtalar joint pronation is a cause because it leads to mid-tarsal joint hypermobility, which we talked about before, which leads to first ray hypermobility because we got the first ray dorsiflexing at a time it should be plantarflexing as we're lifting our heel off the ground. And that leads to jamming and first MP joint stability. And then if you have any metatarsus adductus or valgus rotation of the first metatarsal head, then that's going to lead to a bunion over time. If you have a rectus forefoot and no torsion of the metatarsal, then it's going to lead to hallux limitus. So hallux limitus and hallux abductor valgus are both symptoms of this mid-tarsal joint hypermobility and result in first ray and first MP joint instability with the addition of either some adduction of the metatarsals or torsion of the first metatarsal. And another way we can get to that mid-tarsal joint hypermobility is through non-rigid forefoot valgus. We talked about that a little bit a few months ago, that non-rigid forefoot valgus leads to the instability of the mid-tarsal joint and that same first ray hypermobility going forward. Change to a different set of slides here. So we talk about this abnormal motion. We talked about this when we went through that first section on just all the motions that occur in the rear foot and the midfoot. Normal heel strike, we want the subtalar joint to be around neutral position, which means it's going to be inverted a degree or two. And then at 25% of stance phase, we expect a little pronation, and that pronation allows for the internal rotation of the leg. During that time, the mid-tarsal joint is unstable, but doesn't make much difference because most of the weight is still in the rear foot or the midfoot. But as we get back to 50% and the leg has now been externally rotating, and what starts the leg externally rotating? Sonam, are you on there? Can you hear me? I thought I heard Sonam check in. Hi, Santa. What causes the subtalar joint to get back to a neutral position by 50%?
Is this in preparation for propulsion?
It is in preparation, but what is it that makes, how do we get from that pronated position at 25% of stance phase to that neutral position at 50% of stance phase? What is it that drives that? Anybody want to jump in?
Not exactly sure.
Alexander, got an idea?
Yeah, the muscle that causes external rotation.
Muscle that what?
The muscle that causes external rotation.
What muscle would that be?
Let's see. I guess it's the gluteals. They're responsible for lateral rotation and reduction.
Well, if you have to just have an isolated activity of the glutes, it would be. So that's, you're on the right track. It is external rotation that does it. Tom, have you got a better explanation?
Well, when you're going, trying to best do this.
Remember when we talked about this a little bit?
Mm-hmm.
What drives the internal and external rotation of the leg that occurs when we're walking? Let me rephrase that. What drives the subtalar joint pronation and supination when we're walking?
The motion
I just gave you motion of what?
of the talus.
Right. So it's really not. It's not that the posterior tibial muscles raising the arch or the peroneus longus is plantar flexing the first ray. It's that the other foot came off the ground and is swinging forward, so the whole body is rotating in the opposite direction.
Mm-hmm.
So now our right foot is externally rotating, and the subtalar joint does nothing more than act as an adapter to the ground, and we get supination through the subtalar joint to allow that external rotation to occur. So the external rotation is driven by the opposite limb swinging forward. But anyway, by 50%, we get to a neutral position. At this time now, the mid-tarsal joint should be in a stable position. Now we should be ready, like Isana said, to lift the heel off the ground and not get that jamming of the first ray. So the bottom diagram here shows us with the heel off the ground, the first ray is plantar flex relative to the lesser metatarsal heads, and we're in a stable position. So this is what that looks like if we do a little cutaway and we look at the front part of the foot. So the subtalar joint is now supinated, the leg is externally rotated, the first ray is plantar flexed, and the entire forefoot is on the ground. Now, if I take off if I don't allow that supination to occur because of one of the things that causes subtalar joint pronation or the mid-tarsal joint is unstable, we end up with this kind of a situation where we've got jamming of the first ray because the foot's remained in that pronated position. I thought I had another slide there. So if we take a foot that's normally, this is a foot with a little bit of forefoot adductus, and we pronate that foot, we automatically get what appears to be a little bit of a bunion and some inversion of the first metatarsal head relative to the second metatarsal head. Now remember we talked about when we pronate, all of the metatarsals pronate, but the first metatarsal pronates less than the other metatarsals. So if we do a cutaway with the first of the toes and take the toes off and we look at this, as we supinate the foot, all the metatarsals would like to invert because they invert with the calcaneus. Everything is inverting with subtalar joint supination. As the first ray plantar flexes, it everts. So if we get normal plantar flexion in the first ray, we get to this everted position. But if the foot stays pronated, and I've done this little kind of dumb drawing here with the heel everted, the lesser metatarsals kind of follow the heel. If the first ray is getting pushed up, as it goes up, it inverts. So now the first ray is inverted relative to the lesser metatarsals, and that's what results in that jamming that we see of the first MPJ. So I said forefoot valgus was kind of a subcase that causes mid-tarsal joint instability, and we'll just take a look at that for a minute. The definition of forefoot valgus, Alexander?
Yeah, having the forefoot everted, collapsing that medial column.
So the forefoot is everted relative to this rear foot, when the subtalar joint is neutral and the mid-tarsal joint is fully pronated and locked. So you need to have all those little hanger-ons in there in order to define it as forefoot valgus. Then there's two kinds of forefoot valgus for compensation, or for structurally. One is a plantar flex first ray like we see here, and the other one is that total forefoot valgus like we just looked at. And I put those in the same basket as forefoot valgus. Doesn't really make any difference to the foot or the floor which one is which, whether we have a plantar flex first ray or a total forefoot valgus. And then we have two subcategories from a functional standpoint. We have rigid forefoot valgus, and rigid forefoot valgus compensates how, Isana?
I guess it'll compensate by supination of the forefoot.
Right, so just like this diagram shows, the subtalar joint supinates in order to get the forefoot down to the floor. So we take that forefoot in order to get that fifth metatarsal down to the floor, we supinate the subtalar joint, and then we're sitting on 1 and 5. So with a rigid forefoot valgus, plantar flex first ray on the bottom, total forefoot valgus on top, we have a very stable medial column because we've supinated the subtalar joint, the mid-tarsal joint has remained locked. With the non-rigid forefoot valgus, how do we compensate for that? Tom, do you remember that discussion?
I don't know if I was here for that one, but dorsiflexion of the first ray.
Well, if it's strictly a plantar flex first ray, it could compensate through just dorsiflexion of the first ray, which would, of course, leave us in a bad situation. If the first ray is dorsiflexed and we're getting ready to lift the heel off the ground, we're going to be jamming that first MPJ, so that's not good. But let's take a total forefoot valgus. How is that going to compensate? How do we get that forefoot down to the floor if we're not going to do it by supination of the subtalar joint?
My guess would be rear foot varus, was compensating with inversion of the heel.
Was that Alexander?
Yes.
So that would be rigid forefoot valgus. If we do it through inversion of the heel and subtalar joint supination, then the foot stays
Oh,
stable.
you said non.
So what we do with a non-rigid forefoot valgus, and I don't know that you can see my hands here, but we basically, with the rear foot straight and the forefoot everted, we just unwind in the middle of the foot. Now, when we do that and we unwind in the middle of the foot, we're left with a very lax mid-tarsal joint now. So as we unwind there, we've got no stability in any direction. So non-rigid forefoot valgus compensates with supination of the mid-tarsal joint, which makes it unstable. And that's where the first ray or the mid-tarsal instability comes from with a non-rigid forefoot valgus. And so that foot is not stable, and over time it'll end up mostly functioning in a pronated position. And I think I mentioned to you before, for those of you that were here, that the non-rigid forefoot valgus is the patient when they're walking down the hall, it looks like one step their foot's pronated, the next step their foot's supinated, next step it's wobbling around, and then it's pronated again. If you watch them walk for a while, it tends to stay in a pronated position most of the time. It's just very unstable. And that instability leads to this jamming of the first ray. And 70% of forefoot variations are valgus. So if I take all the patients out of I did a series, 45 years ago where I took 300 consecutive patients, 70% of them were valgus if I looked at forefoot valgus and varus. And 70% of those that were valgus function non-rigidly. So that means half of all the patients that have a forefoot deformity, varus or valgus, and that includes a plantar flex first ray, function as a non-rigid forefoot valgus. So when I had that diagram that I had subtalar joint pronation on one side going up and mid-tarsal joint hypermobility, half of it comes from that non-rigid forefoot valgus, half of it comes from the subtalar joint pronation from other causes. So this is an important cause of bunions. And what do we do about that? How do we make that foot function normally if we've got this foot functioning like this? So we're going to be talking orthotics here. What do we do about an orthotic to keep the foot from doing that?
You can put an orthotic with like a lateral post.
So we'd use a orthotic with a lateral post. So we use a forefoot valgus post to support that forefoot valgus so we don't have to have the mid-tarsal joint collapsing and becoming unstable. Now, since that's an unstable kind of foot, the arch support on this thing is important. So the arch has to fit exactly to the shape of the foot for this to be effective. But it's that forefoot valgus wedge which locks the mid-tarsal joint again, which allows this foot to function normally. Does that make sense? If we have a rigid forefoot valgus, the forefoot valgus post does away with the need for subtalar joint supination. So we use the same kind of post, but we no longer need any arch support. All we need is a little wedge under the forefoot for that one. With an unstable non-rigid forefoot valgus, we need both the post and the arch support. So how about metatarsus adductus? Why would that cause a bunion? Other than setting us up with having the normal digital abductus, I thought I had that. Go back for a minute. We've got a metatarsus adductus, the long axis of the second toe and the long axis of the hallux basically follow the long axis of the rear foot. So the more adductus we have of the metatarsals, the more normal hallux abductus we have. So we can have a neutral position foot that has a large amount of metatarsus adductus, and it's going to have a high degree of hallux abductus even before we start to get a bunion. So that sets us up for getting a bunion. And then what is the functional cause? What makes the mid-tarsal joint unstable in this foot? Alexandrians. What makes this foot pronate? Tom?
The collapsing of the heel arch.
Well, a collapsing arch is the pronation, but what drives that? Tom, you got an idea? What? For some reason, I'm admitting people and they're not showing up, so I don't know whether they're here or not. So I'm gonna have to pick on those of you I have pictures of.
I'm not sure.
Well, we looked at these slides before with an adducted forefoot. How is that foot gonna fit into a shoe?
Okay. I'll tell him.
Needs to be pronated. Yeah.
Right,
Mike,
yeah,
Marty just called. He said he's trying to get in, but he can't.
I'm not sure what to do.
You don't see him?
I don't see him. And I'm not sure I can stop screen sharing maybe. I don't see him on the list of trying to get in. Sigh, now I see somebody else. Now I have somebody else to pick on.
Sorry, I was driving earlier, so I didn't want
That's fine. I just couldn't see you, so I didn't know whether you were here or not. But I don't see Marty on there, Paul.
No, I don't either.
And I've got a list, but it isn't to pronate, right? I mean, if that's what a foot looks like when it's in adductus, there he is. I don't see him, but I think he's there. Dr. Pressman, are you on board?
I'm on board.
Okay, I don't see you, but now I know you're here. So metatarsus adductus is a cause for bunion. Both we have the forefoot adductus that causes that high degree of digital abductus that's normal. And then we have to push on the medial side of the foot to get it into a shoe. So with metatarsus adductus or forefoot adductus, the shoe becomes a pronatory force. So if we've got the pronatory force aimed right at the first metatarsal head in the hallux, and we've got a high degree of digital abductus, it sets us up for getting a bunion. And there's nothing you're going to do with an orthotic unless the shoe allows the foot to stay in that position to take that pressure off. Now, you can correct the metatarsus adductus, but from an orthotic standpoint, you can't do anything without an in-flare shoe that's going to match the shape of that. Oh, there's the diagram I was looking for, all the way back to. So that normal amount of digital abductus that we get with a adducted forefoot is a predisposing factor to developing a bunion because the high degree of hallux abductus that is present before we start to get the instability of the first ray. So you take a foot like this and you add some first ray jamming to it, and you're going to very quickly end up with a bunion. So how about forefoot varus? Somebody want to give me a definition of forefoot varus? No, nobody wants to.
Fixed position of inversion of the forefoot.
Relative to the rear foot when the subtalar joint is neutral and the mid-tarsal joint is pronated and locked.
That's what I meant.
So it's so Alexander gave me that much of a definition before, but then got sidetracked for forefoot valgus. So forefoot varus is this kind of a situation if we just do a stick diagram of it. How does that compensate? Sai? How do we compensate for forefoot varus?
Probably bringing down the medial column.
So how do we bring the medial column down?
In terms of like when you're talking about orthotic posting,
I'm just talking about a patient stands up that has forefoot varus. What happens to their foot?
you would see the medial column come down. Your first ray would plantar flex.
Where does that motion occur? Where does it come from?
It's happening at the first MTPJ.
No. How does that forefoot get down to the floor, Tom?
Subtalar joint pronation.
Right, subtalar joint pronation. So when the subtalar joint pronates, That puts us back on one of those pathways we had to get a bunion, right? That was one of the main pathways to develop the mid-tarsal joint instability. First ray instability, first MP joint jamming, and you develop a bunion.
And the
So
first
if
ray
I-
dorsiflexes and inverts like this picture.
Right, you missed the good part. Sorry, Dr. Pressman.
Sorry.
So what happens is the first metatarsal inverts relative to the lesser metatarsals, but everything is everting. So if we have this kind of a situation, we're going to have abnormal function. How are we going to stop this foot from pronating? We use an orthotic with a little 4-foot valgus, 4-foot varus wedge. And that 4-foot wedge does away with the need for the subtalar joint pronation. And so if we've got a bunion that's being caused by 4-foot varus, if we can control that with a 4-foot post and an orthotic, then if we fix that bunion, it's not likely to come back. So how about Aquinas? How does Aquinas cause bunions? So what are the different methods? I don't know if anybody was here, but we touched on compensation for Aquinas. What are the different kinds of compensation for Aquinas? Anybody remember any of them?
Abducting the forefoot.
Abducting the 4-foot? Is that what you said?
Yeah. Maybe.
Well, pronate, you pronate. So what you do is you pronate, you end up with a situation like this. So you pronate the mid-tarsal joint and the subtalar joint to gain a little bit of dorsiflexion in the midfoot. So that can happen. Do you remember from the, where did Isiana go? Is she still there someplace?
I'm here.
So do you remember when we were talking about those Johnson and Chrisman articles, what happened with Aquinas to the first ray? That part 5 of that series?
I think it causes valgus rotation of the first ray.
It causes valgus rotation, or it decreases the amount of, what does the peroneus longus do to the first ray normally?
So normally it would plantar flex it and evert it.
It everts it and kind of tightens up the whole midfoot and doesn't really cause much plantar flexion, but it makes it stable. And when they've had an Aquinas along with it, it was unable to do that eversion and stabilizing the midfoot. So when we've got an Aquinas, it doesn't allow that first ray segment to lock and does allow some mid-tarsal joint pronation in the first ray to go up. That's all part of this compensation through mid-tarsal and subtalar joint pronation. What are some other methods of compensation for Aquinas?
Early heel up.
Early heel off is a good one. I like early heel off for a compensation because it doesn't do any damage to the rest of the foot. May cause a bouncy gait, may cause a little lack of shock absorption, but it's actually protective for the mid part of the foot and the forefoot. So that's actually good. Another method of compensation. How about short steps? You know, if you only take a half a stride, you never get your leg hyperextended behind you and you don't need any dorsiflexion. Another one is abduction. If I abduct my feet until they're abducted 90 degrees, I don't need any dorsiflexion. So as you abduct, you need less and less dorsiflexion. As you take shorter steps, you need less and less dorsiflexion. But the first two are the ones that we think about the most, and that's this compensated Aquinas and the early heel off. Compensated Aquinas, if we look at a diagram, looks just the same as all these other pronated feet. So we've got a foot that pronates. How are we going to control this with an orthotic?
Heel lift.
Heel lift. And why does the heel lift work?
Mimics early heel off.
Yeah, because then what we do is we take a normal, we put the foot back in a neutral position and we make an orthotic so the arch is supported. And then we add a heel lift. And what the heel lift does is it trades the pronation compensation in for an early heel off compensation. And it doesn't make any difference how we build that into the orthotic, but if we use a heel lift, it allows the early heel off to compensate for the equinus rather than the pronation in the midfoot. So from an orthotic standpoint, that's the way we'd go about addressing that. And we get a little added bonus. Remember, when we lift the heel, we supinate the whole foot because of where the ankle joint axis is, the tips of the malleoli. The ankle joint is really a pronation supination joint. It's not a dorsiflexion and plantar flexion. So if we lift the heel, we supinate the entire foot. Again, making the foot a little bit stronger. So I like to think about when I'm dealing with bunions, I like to think about identifying what the cause might be. And it could be that when we look back of it before, inflammatory disease was a cause, trauma was a cause, valgus rotation of the first metatarsal head was a cause, forefoot adduction can be a cause, mid-tarsal joint instability can be a cause through subtalar joint pronation or flexible forefoot valgus. Once we identify the cause, we need to decide whether that's correctable or controllable. Some are either. So when I'm treating patients, my normal thing would be to try to control the way the foot works first. And if I can control it, then select procedure based on that. If I maintain control, I'm likely to maintain correction. Does that make sense?
Yep.
So anybody have any questions about that? So I think that, I know we've got some time left, but I'm getting some feedback. I'm not sure who it's from. So that's where I was planning on ending. I'm not, really the idea is be sure that you can identify what the cause of the bunion is, do something to control it. And the reason we're a little bit short is I didn't want to spend all that time on first metatarsal torsion. If nobody has any questions, you guys can log off and I'll go over that first part of it with Dr. Pressman. So is Tom still there somewhere?
Yep, I'm here.
Do you have any questions about that?
No, sir.
Does that make sense to you?
Yep.
And I think it was a Payal that was talking last time about not believing there was first metatarsal torsion?
She might have
Were
been.
you
I don't think I was
Were
on.
you, I don't know who was there last time, but I think it's almost like I'd like to have one more chance to talk to her about it because she seemed to be convinced by somebody else that there wasn't any torsion. Is there anybody, if there's anybody else there that has a problem with this torsion, I'm going to go back and drag Dr. Pressman through it since I've got his attention.
Because I don't believe in it.
That's right.
I'm
And
gonna stick around actually if you're gonna talk about it because I wasn't here for the last one. So
Okay, well, I'm going to go back to that stuff that I was just looking at then. Anybody that doesn't want to see this stuff again, go ahead. You feel free to log off. I'm not going to feel bad. There he is, Dr. Pressman.
Hey. I'm still in the office, but I wanted to get on this so I could learn something.
So this is just a real short, probably 5 minutes here, on how I decided that there is valgus rotation of the first metatarsal. This
In
was
some
presented.
patients. In some patients.
Just
that what
let
you're
me give me 5 minutes, and then we'll have a little discussion in the.
Okay.
So this was presented by Puccinelli, one of Don Green's residents at the Podiatry Institute meeting in 2016 in San Diego. And they took 60 patients, 30 of who had hallux abductal valgus and 30 who had hallux limitus. And they measured this frontal plane rotation of the first metatarsal using 3D CT weight-bearing scanning.
Gotcha.
And what they found was there's a whole bunch of information here that's kind of interesting that we can spend some time going over. But this frontal plane rotation down here in the hallux abductal valgus patients averaged 19 degrees. And this frontal plane rotation in the hallux limitus patients averaged 3 degrees. So this is the first time I'd seen it presented like that. This was after a few years of Dayton and a bunch of the other guys talking about this pronation of the first ray and the need to do a derotational lapidus and all this other stuff. And I was having a real hard time buying the idea that they need just strictly inverting the first metatarsal was going to solve this problem. So when I heard Puccinelli give this presentation, it's like a light bulb went off. Aha, there must be something going on, that there's a difference in the structure of the first metatarsal. Now, they came to the conclusion in this paper in 2016 that it was actually the bunion formation that was driving this eversion of the first ray, and that it was a result of the bunion rather than a predisposing condition. And I wasn't so sure of that. The next year, Oda published this paper, and they had 30, about the same size. They had 31 patients with bunions, 32 patients with controls, and they were measuring the first metatarsal proximal joint surface to the distal joint surface. And I'm using that distal joint surface as as being the same as this crista was when we were talking about in the last time, and they're not exactly interchangeable. And what they found is there's a significant amount of external rotation in the first metatarsal in hallux abductor valgus, and the external torsion did not increase with severity of HAV. So because of that, they're thinking, well, maybe this is a predisposing factor to the bunion, not a result of the bunion driving this pronation of the first ray. And that made more sense to me. This is what they came up with numbers when they were doing that. They had 18 degrees and 5 degrees. So the bunions had 18 degrees of eversion of the first metatarsal head, and the control group had 4.7 degrees. So I went, when I was at Doctor's Hospital, I was at the Podiatry Institute meeting. This resident McNamara was looking for some kind of a project, and I talked to her about this, and she agreed to do this. So she went back and did the weight-bearing CT scanning again, looking for this, and they were measuring we measured a whole bunch of stuff that I went over last month, but the thing I'm looking for here is just the amount of torsion within the first metatarsal. And the torsion in the first metatarsal ended up being around 10 degrees. So the normal amount of torsion in a, I'm going to have to get that on without a, again, I got people, anyway, there's a normal distribution, but it averages out right at 80 degrees. And the standard deviation is being about 7. Nobody had an inverted position of the first metatarsal relative to the base of the metatarsal. Everybody had some eversion within the metatarsal, and it was up to 35 degrees. So it could be a lot of eversion.
These are
And
normal patients?
this was a cross section of 100 consecutive patients. So there's
Bunion, no bunion?
Bunion,
normal.
no bunion, normal.
Okay.
So
No.
this was just to come up with an idea of what's going on. And so what we did is we measured the first cuneiform, the navicular, the first metatarsal base, the first metatarsal head. All the proximal structures moved together. The torsion within the metatarsal was completely separate from any motion of the cuneiform or the navicular in the frontal plane. So the frontal plane deformity was all with torsion within the metatarsal itself. And since then, there's been a bunch of studies that have been, there's 2 or 3 studies, it seems like every month, showing up now that show this external, what they're calling external torsion or pronation within the bone itself. I consider it a valgus rotation within the metatarsal.
Right, and these are in normal feet.
This is normal, but it predisposes, if you've got an everted position of the metatarsal of 10 degrees, and then you've got a mid-tarsal joint instability, you get a bunion. If you don't have any external rotation of the first metatarsal and you have mid-tarsal instability, you get hallux limitus.
Mm.
So, you know, the business we've gone through for all the time we've been in practice about trying to decide which one of these feet that look like they're functioning pretty similarly develop bunions and which one develop hallux limitus, and thinking that the pathway looks similar with that first ray jamming. I think it's the valgus rotation of the metatarsal that's
How about
one
length?
of the differences. Length is a difference.
How about male, female?
Amount of adduction is a difference.
How about male, female?
Female is a difference, but there's, I'm not sure why. Is it shoes or is it a little bit more mobility? You know, there's females tend to be a little bit more lax than males. Joint
Right, their ligaments are
laxity.
more lax, their crista's not as big.
There were, so, you know, all those things are predisposing, but I think the valgus rotation of the metatarsal is a major predisposing factor. And I've got a whole bunch of slides on the way we went through and measured all this stuff, but that was kind of the bottom line conclusion.
And so your measurement, was it done with a CT scan?
Yes. Yeah. And so we measured, you know, like I said, we measured the navicular to the first metatarsal, the cuneiform to the first metatarsal, the base to the head. We measured all these things and it came out that the valgus rotation was always within the metatarsal itself.
And did you look at it, whether these feet were pronated or neutral or supinated?
No,
Was it a
not
weight-bearing CT?
weight-bearing CT.
Right. So,
Yeah.
so the question is, if you do a CT scan on a maximally pronated foot, and you say the whole, and you get, you're looking at it, are you looking at the distal end of the metatarsal compared to the proximal end? Is that what you're doing? To
Right.
see it? Yeah.
Right.
But that,
So
so
what
that
happens
doesn't,
is the torsion's in the metatarsal. So
so it
all of
doesn't matter. Right.
the whole medial column can be everted, but the torsion in the metatarsal is added on top of that.
Right. Okay.
So the in the frontal plane, the navicular and the first cuneiform and the first metatarsal base all go pretty much together.
Right.
And that was kind of shown when we were looking at all that stuff from Cherry Johnson and Jeff Christensen in that series that you so eloquently read for me last time. And so everything moves together in the frontal plane, but there is this built-in torsion in the metatarsal, and sometimes it's greater than others. And I've got I don't remember what you saw, Marty. Did you see that stuff on any of the other stuff on the first ray that I did?
Today?
When I was no, when I went
Oh,
through
yeah.
some of the study and measured all the angles.
You mean last time? I was there for the whole thing.
Time before last, I think. Well, I don't know
Oh, I
if it
think
was
I
last
mi-
time or not.
I don't know if I saw that. No.
Well,
No.
anyway, so the difference, I think what it is I think the first metatarsal and all the metatarsals evert with pronation. The first ray axis causes the first metatarsal to invert a little bit relative to the rest of them. But if everything everts, the first metatarsal may be still everted a little bit.
But there's a dorsiflexion inversion moment, right?
Right. But if it
So-
starts out 35 degrees externally rotated, it's still
Right.
going to be externally rotated.
Okay, but the force on the first ray, even if it's everted, is a dorsiflexion inversion force. It's a moment where the ground reactive force, when it
It was
pushes
trying-
up on that everted, it's trying to dorsiflex and invert.
It's trying to
And
push
it's,
the first
and it's resisted by the sesamoid crista interface and the medial sesamoidal ligament, which holds the tibial sesamoid on the medial side of that crista. So for every step you take, everted or not, there's
Right.
a dorsiflexion inversion moment that's stretching your medial sesamoid and
Right.
creating a impact of
But
your
if-
crista to the
But
sesamoid.
what this study suggested, when we went back to that, now we had on that study that Puccinelli did, they had 30 patients that had hallux limitus. So they still had pronation, jamming, mid-tarsal joint instability, all the rest of it. But they didn't have the valgus rotation of the first metatarsal head. So they had the same pathomechanics going into the first ray, but they didn't develop a bunion, they developed hallux limitus.
Yeah, but how many of them were men versus women? And how many of them had very,
They were 50-50, men and women.
with hallux limitus?
Right.
Yeah. Well, so, to me, I look at the hallux limitus as first of all, the prevalence is 3-to-1 male to female, right?
Right.
And bunions are 3-to-1 women to men, but the
Roughly,
pathomechanics is the same, right?
Right.
So there's a sex-linked difference between hallux limitus and rigidus and hallux valgus.
I'm not
It's like-
arguing that.
And so it's like a Venn diagram. It overlaps.
And I don't want to take any of that. What I don't want to do is I don't want to take any of that away because the basic mechanics that we've always thought about, I think is correct.
Right.
But I
So-
want to.
So there
but I want,
there are structural differences between.
But I want, right, but I want to add into that,
Mhm.
that some of these people have a valgus rotation within the
And some
metatarsal
don't.
and some don't.
Oh, yeah. No,
So if you take all the
Dayton
stuff that you're
said that.
normally doing
Yeah.
and you add that into it, then that helps explain some of these patients that we had a hard time understanding which was going on.
why they have a bunion and the sesamoids are
Right.
look like they're in a normal position and it looks like
Right.
it's everted when
So
it
you
should
remember,
be.
do you remember
But
those?
how many of those bunions with with eversion had the tibial sesamoid on the lateral side of the crista?
There's studies, I don't have those studies
Because
loaded up right now, but there are studies.
Yeah, so
There
you
are
look at
studies
Dayton.
that show what happens is so there are these patients that have this everted first metatarsal. Some of them, the sesamoids are still where they belong.
Right.
They just need a rotation of the metatarsal. Some of them have an everted metatarsal and the sesamoids are displaced as well. They need a relocation of the sesamoids and possibly a derotation.
Right.
So there's two different categories. So
Right.
you can have a metatarsal that sits square with displaced sesamoids.
Right.
You can have a metatarsal that sits square that doesn't have displaced sesamoids, and you can have both situations with the rotated metatarsal.
Right. And you can have a
as-
metatarsal that's inverted with displaced
No.
sesamoid.
There aren't any inverted metatarsals.
There's no inverted first metatarsal?
Not in this,
So when you-
not out of 100 patients. I'm not saying they don't exist, but we took 100 patients. There weren't any in 100 patients.
I'm not talking about torsion. I'm talking about the position.
I'm
It's like a
talking about I'm talking about there weren't any. There weren't any inverted out of
not-
100.
Really.
None. So that doesn't mean there aren't some, but it's
So
an
when you
outlier.
take an axial view of a bunion and you see the sesamoids, the tibial sesamoid is on or over the crista, the first metatarsal looks like it's dorsiflexed and inverted.
The first metatarsal typically looks like it's square when that happens, or everted a little bit, but the sesamoid is riding under the crista. That's correct.
But the
But it's not-
metatarsal
but it's
looks like
not
it's inverted.
No. I think you look at them again. What it is, it's inverted relative to the sesamoids, but it's not inverted relative to the ground.
Well,
Seldom ever. My diagram showed it that way, but we didn't find any that looked like that.
really.
So think about, it just takes a mindset. You know, it took me I struggled with this for several years till it finally, dawned on me what was going on.
Right.
So it adds into all the other things that we normally think about what's going on with the bunion. It
Right.
just adds this valgus rotation in.
Yeah, no, I'm sure it exists. I'm just wondering if it's a variant or it's the major thing, because even Dayton said when he was talking about the derotation lapidus, he had some other groups where he wouldn't have done that because the metatarsal was inverted or the sesamoids were completely out of place.
So you can have metatarsal head that's straight
Right.
with the sesamoids located. You have metatarsal head that's straight with the sesamoids dislocated. You can have valgus rotation of the metatarsal with the sesamoid still in place.
But you
or
can't
with
have
the-
an inverted first
but you don't-
metatarsal.
I'm not saying you can't, but I didn't ever see any when I was doing this study.
But if the ground reactive force is creating a dorsiflexion inversion moment, and you lose the sesamoidal apparatus, which direction is the first metatarsal going to go as it dorsiflexes? It's going to dorsiflex and invert.
It's because we have instability and pronation in these feet, so everything everts. So the first metatarsal may invert, but it's not inverting far enough to make up for the overall amount of eversion. In most cases, this isn't absolute.
Right.
This was only 100. This was only 100 patients,
Right.
and we only looked at groups of 30 with bunions and without bunions.
Right.
But I'm pretty comfortable that there's most of the time, you just need to add this in. What we need to do now is we need to do a study with the computed tomography and regular sesamoid axial views and see how they correlate.
Right.
And
Right.
then it becomes clinically useful for everybody in practice.
Right,
So if you don't have a, a curved beam CT scanner in your office, you can't look at this the same way that we did in this study.
right,
know.
right, right,
But when we started doing this, I was still doing sesamoid axial X-rays,
right.
and there was, and I've got those X-rays in here someplace that I've shown you before with those two bunions that got fixed, and they looked like they were in good alignment on the sesamoid axial, but you look at the AP and the sesamoids look like they're way the hell out of position somewhere.
Right, right.
I'll see
Yeah,
if I can. I'll see if I can find those again.
Yeah, yeah. And the other, sesamoid axials, the heel is raised, the foot is supinated in order to get them.
Right.
So that throws all of that off as well.
Nope, not there. So these were the ones I was talking about. So this is a female, but this is a male.
We can't see him, Mike.
You can't see the shear?
All
No,
he-
a lot of these hallux limitus cases and ridges cases, the first ray is elevated and long. And so the question is,
But you can also have bunions with a long first metatarsal.
yeah, absolutely. Yeah,
And you
absolutely.
can have bunions with an elevated first ray.
Right.
So
when
the,
it's,
well,
but
the
if it's
pathomechan-
hypermobile and elevated, why isn't it elevated and inverted?
it does invert a little bit, but everything everts when it's hypermobile. The whole foot is pronated. And when
Well, not
the whole
all of
foot,
them.
when the foot pronates, everything everts.
Except for the first metatarsal, which dorsiflexes and inverts.
Relative to the second metatarsal,
Right.
but it everts relative to the floor.
Sometimes.
I'm just saying you just need to add this onto your, I don't think there's anything wrong with the way you think about it. You just need to add this on as one more.
It's
one more
another
variable.
category of bunions with
Right.
with torsion. And I don't disagree that the foot's heterogeneous and that any of those things are certainly possible. And so it's just another group of types of bunions where there's valgus rotation. But I don't know what size that group is compared to what I'm seeing. But when I see a severe bunion with the sesamoid on the lateral to the crista, and I take an axial view, it looks to me like the first ray is dorsiflexed and inverted, not everted. I don't see them everted. Now, it may be my sesamoidal views are taken on feet where the heel is raised so you can get the x-ray. And so, it looks inverted because you're taking out the pronation to get the sesamoid views, right?
You do take some out, that's for sure.
Right. So that may give us all false.
But I've got, I
Positive.
wish I could, I've lost control here.
Hmm.
I can't get that back up.
Well, Dr. Pressman, do you want to give your Lapidus lecture next time?
I'll give my anti-lapidus.
And in the meantime, Dr. Burns, you can find those slides so you can argue with him.
I have no argument about it. I don't think you need to do a Lapidus for these. All you need to do is just cut the metatarsal someplace in the middle and rotate it.
Well, yeah, and you saw that article with the 10-year follow-up where they did a metatarsal. It's like they did a mid shaft and they just sort of turned the head, moved it
Right.
over, and pinned
Right.
it. And
Drado
Drado works.
right.
Right.
So I mean the Drado does the derotation, and it doesn't have to be at the base.
And they measured hypermobility, and it didn't matter 10 years later whether there was or wasn't. The bunions were okay anyway.
Yeah, but remember the business about getting the sesamoids line back up that we just did with the first ray series last month.
Yes. Yeah.
Once the sesamoids are back in position and the windlass works, then the first ray becomes stable.
That's right. So the hypermobility of the first ray has to do with first metatarsal phalangeal joint stability, not
Right.
some problem at the metcuneiform joint
Right.
or the peroneus longus.
It's a combination of all the things, but if you get it lined up again, that one study they did that they did nothing more than just line up close the IM angle. The
Right.
first MP joint became stable in that
Correct.
cadaver
Yeah.
study.
Yeah,
Right.
yeah.
So I have no argument with the lapidus. I just think it's just one approach. It isn't needed to derotate the metatarsal, that's for sure.
Right, right. And not needed to give you first ray to deal with first ray hypermobility either, because the hypermobility doesn't come from the TMT joint. That hardly moves. The
Right.
hypermobility comes from the instability of the first metatarsal phalangeal joint and subsequent hypermobility to that.
So
That's-
Isana, do you remember what happened in that Johnson and Christensen article when they did a lapidus and then tested again with weight bearing?
I don't
No.
remember.
I don't
Do you remember,
sorry.
Marty, what happened? So what happened is just made the peroneus longus more effective at everting the first metatarsal.
Yeah,
It didn't necessarily reduce the amount of, it just made everything work a little better. And if you fused the first to second rays, it made it work a little bit better yet.
right.
But it doesn't necessarily reduce all the hypermobility.
No. So when you get the windlass effect and the
Right.
sesamoids back in alignment and the ligaments around the first MPJ retighten, then you've got stability of the first ray.
And you derotate the metatarsal head so it's back straight.
If it's rotated.
So
I
I'm
mean,
not-
I don't know how you know that without a
If
CT
it's,
scan.
if, I think you can, well, I'm gonna call me back and I'll show you.
All right. I need a clinical
We can end
way.
this, and I'm gonna
to
have
know.
to start. No, I'm gonna have to start a new Zoom, but I can show you an everted metatarsal with a weight-bearing sesamoid axial. I've got one here on the screen. I just can't get
Well,
it to show.
I'm sure they exist. I wouldn't even argue the fact that it doesn't happen. I'm just, there because I know it's heterogeneous and anything like that is possible. But in general,
No, but that's where the problem is. It's not in general. It's usually everted. So that's what you have to get. Once you start looking for it, you'll see.
well, I
it.
got to see that. I'll have to see because what I'm looking at with my sesamoid axials on bad bunions and sesamoids out of position is the first ray is dorsiflexed and inverted, not everted.
Are you doing a sesamoid axial on all your bunions?
Yes.
So you are looking at that.
Oh yeah.
Because I did sesamoid axials for years, and I always assumed, like you did, that the supination of getting them on the orthoposer and pulling up the hallux pull the sesamoids back into alignment.
Right. You have to dorsiflex the hallux. So plantar flexes the first metatarsal, plantar flexes and everts it.
Right, and I thought that's why that's what I was seeing.
Right.
But that's not what the deal is. It actually is everted.
All right. Well, I'm ready to be convinced.
Just think about it when you're looking at them.
All right. Okay.
Sorry for you guys getting in on the rest of this argument.
That's how you learn.
Yeah.
I'm
Adios.
asking the questions. Yeah.
All right.
All right, till next month.
Okay. See